Okay, so I think I saw Indu. I'll turn it over to you. Oh, there you go. So yeah, you're muted, but oh, there you go. So welcome. I'll cede the floor to you to get us kicked off.
Okay, sounds good. Thanks so much, everyone, for joining from Virtual Support Group Land. It's great to see everyone and continue the connections through this portal. Thanks, PMD Alliance, for hosting this. It's been a pleasure to grow this series of talks. So we bring you this talk today because of your own interests. This is something that patients have requested, demanded, been excited about. And I have to be honest, I actually was not the most excited to be hosting this for whatever reason. I am maybe have my own cultural or personal, I don't know. It was a little interesting mentally for me. So I'm just telling you that at the top of the hour. And hats off to Miriam for putting the slides together and really owning this topic. It's such an interesting and important topic that I think I represent probably many other physicians in our probably discomfort sometimes in bringing these issues up. And so wanted to, address the concerns and questions and interest of our audience and have Miriam on, who's agreed to join us on I think it's like a Friday night in the summertime is finally hit in the UK. So she's taking an hour out of this gorgeous night where she could be enjoying a glass of something somewhere else. So really appreciate this. Miriam is part of the King's College group, which is just this fabulous gang of people. They're just so passionate about taking care of Parkinson's patients and in a holistic way, looking at non-motor issues, which are just so important. And so when we talk about Parkinson's, most of us spend a lot of time talking about the motor issues. We're really going to be bringing a series of talks to you around non-motor issues, starting with this one. There's one on the bladder on Monday from another friend and guest and colleague from the UK. And then Miriam's colleague, Ray Chowdhury, who's really the world expert and non-motor king, I guess, as we can call him, will be coming to us in the next few weeks as well. So just really excited to bring you this important topic. So maybe I'll start, Miriam, with just sort of introducing you through a series of questions, just asking you a little bit about yourself. So you're a nurse specialist in Parkinson's. And I wanted to find out how you got interested in Parkinson's and how you ended up coming to the UK, because you're originally from Israel, aren't you?
Yeah, that's right. Good evening, everybody, or good afternoon for your time. Thank you for inviting me, first of all. It's a pleasure to join you. So, yes, I came to the UK in my early 20s after completing the military service in Israel. At that time, I did not think that I'm going to become a nurse. But I had a very dear friend of my family visiting me here. And she was a trained nurse, and she trained at the Netherlands. And she said to me, I always can see you as somebody that's going to pursue something in medicine. And really, rather than doctor, I can see you as a nurse. And I kind of thought about that. And while I was here, I thought, well, I will apply for nursing, and applied to 3 very prestigious hospitals here in the UK. And suddenly I was offered 3 places, and I had a choice. And so I decided to train at Guy's and St. Thomas's Hospital. And this year we're celebrating 200 years since the Florence Nightingale established the first ever nursing school in the UK, in fact in the world, in the 1860s. And yeah, so it was from then onward, I'm just here.
That's amazing.
And the reason I chose Parkinson's speciality. Well, in the UK, you go through the general training and you qualified as a registered nurse. And then normally you join a general kind of nursing. I was on a neurology ward and exposed to many neurodegenerative conditions, which I found very challenging, very interesting. And then I decided to move to the National Hospital for Neurology, Queen Square, which again, a fantastic place to work and become a clinical nurse specialist there. I covered many areas there, and I worked in many specialities, including neuromedicine, neurosurgery. That really was of most interest to me, for me, was the Parkinson's service. And so I joined the team there, and from there I moved to King's College London. I found Parkinson interesting because it's an area that I feel that we can make a difference as nurses, particularly as clinical nurse specialists. We have a very important role. It's a role that can influence people's life, quality of life, in so many ways. And our role is so vital here for people with Parkinson's disease, as we are the key person that they are able to contact us on a daily basis. We have our nurse-led clinic where we see people with Parkinson's disease independently, advising them on many aspects, including medication, healthy lifestyle, all kind of social aspect, education, and it's an area that is forever growing, and you always review what you do and you evaluate and you want to make it better and better for people with Parkinson's.
That's amazing. Could you tell us, because I think that the U.S. doesn't have nurses that are necessarily as subspecialized in a disease, and this whole concept of a clinical nurse specialist, and I know you've done recently some work getting all the clinical nurse specialists in the country, and I think you've even had some international nurse specialists join from China, you said, and stuff, because I ended up giving a talk for your series. And so can you describe a little bit about that type of network and how you fit in with the care of Parkinson's patients and how it fits in with, for example, a neurologist? I think people in the US are really kind of jealous. I already see a comment or two about how we wish we had more here. And so tell us a little bit about it, what you've been doing, especially in the COVID timeframe, to connect these folks, and how you sort of, envision your role.
Okay, so the nurse specialist in Parkinson's disease in the UK is very established. Currently, we have 400 Parkinson's nurses in the UK, all working in different settings. For example, I work in a hospital setting. Some nurses work in the community. Some have a job share between the community and the hospital. We fit within the service as coordinating the service in Parkinson's. We work along with all MDT discipline. The neurologists normally see the patient approximately twice a year. We fit in between. So where they see the neurologist, within 3 months they see us, and then they see the neurologist thereafter. Our role is to connect the patient as well with the neurologist. Although we don't diagnose the Parkinson's disease initially, as soon as a person is diagnosed with this condition, they are referred to our services. And we try to see them as quickly as we can in order to provide support, education for them and their family. So within the UK, as I said, there's the 400 nurse specialists, and during this period, which is so strange and so unreal for all of us in this time of this pandemic, I found myself being redeployed to intensive care. We all had to help with fighting this COVID-19. And so I was working in intensive care with a team that I didn't know, away from my team, in speciality that I did not practice for many years, very out of my comfort zone indeed. But I learned quickly, we all had to help. And during that time, I felt quite isolated. And I kind of thought to myself, like me, there's many nurse specialists across the countries that are redeployed and on their own. Their team, their neurologist, been redeployed to help as well. And I felt of a way of connecting us and helping, sharing information, what's happening elsewhere in the country, and how we're going to help each other during this time and connect. And so we developed this weekly platform using Zoom, whereby we are meeting for an hour and from different parts of the country and sharing information about how to treat people with Parkinson during this pandemic. And there's a lot to be learned and there's a lot to adjust. Our service has to be adjusted. How are we coping with being able to provide service while working full-time in intensive care as well? So this platform allows to connect and share ideas, information. We were able to bring so many topics to this platform in terms of covering different areas, such as the kind of service we have to move towards during this pandemic, conducting phone consultation, for example, what kind of performer are we using? And for example, I set this performer how to conduct a consultation over the phone, a consultation that's going to be effective for people with Parkinson's disease. And it's need to be different. And so I shared it amongst my colleague. And of course, by no means that's the only way to do it, but it's a way to start. They can change it, adapt it to their own services. And from then onward, we thought of different topics that we can share. For example, people with Parkinson's disease, how are they going to contact us during this period of time? And so the advice was to put out of office reply to our email if they're contacting us that way, and list in that message to them how they can contact us, how they can contact emergency number, for example, what kind of service we're going to provide, and to give them that kind of link that we are still there for them. Another example on our phone messages, what kind of information they need to know so they don't feel on their own. Many of them will know that we've been redeployed, but we're still there for them, although in reduced capacity, but we are here. In terms of education for the Parkinson's nurses, we brought different topics, such as we brought Professor Chowdhury, for example, to give us an update as to how COVID-19 and people with Parkinson's disease, what kind of effect it will have on them. Are they at a higher risk, etc. And he provided us with a very good session on that. We had a session about how to set a support group from India who joined us. Thank you very much. Mm-hmm. And that was very, very inspiring. We had looking at palliative care during pandemic. And unfortunately, we did lose many people with Parkinson's, particularly the one that was quite advanced. And how are we going to provide the care for them? And what is the right care for them during this period? We're talking about other areas of, and we're going to have a topic about nutrition, complementary therapy, and so on.
Yeah.
So this way, we're connecting together and sharing information.
That's great. That's great. All right. Well, I think the audience is very hungry for your topic on sex. I'm seeing all these comments about that. So maybe we'll transition to that. But thank you for giving us that background, because I think since you have been doing all this important work, and I think it's important for people to understand the structure of how it works in the UK that's different than here. And so maybe, you know, I think it's very helpful for me to understand, and some of our other audience as well. So I'll let you maybe transition. I think you were going to do some slides, right? And then we're going to move on to some questions.
Okay, so I'm going to share my slides, and you can all see the slide now?
Yep.
Excellent. Yep. So the topic that I'm going to talk about is about recognizing sexual and relationship issues in people with Parkinson's disease. It is a very sensitive topic, very private, and like Indy said, is a topic that even us clinicians have kind of barrier about talking about it. Not just you, people with Parkinson's disease. It's a topic that unfortunately is not openly discussed in our clinics and often is being ignored. As such, I see people with Parkinson's coming to my clinic, and although we give them the opportunity to raise that topic, it's rarely or nearly not often been addressed in our clinic for many reasons, and I will go into that now. The reason I have interest in this topic is because sexual dysfunction is common in patients with Parkinson's disease. We know that 57% of patients with PD reporting altered interest in sex. We also know that 66% of patients with PD reporting problem with sexual intercourse. There's a study that conducted in the UK by my colleague, Dr. Annette Han. She's a nurse consultant in Parkinson's disease. And she looked at sexual and relationship dysfunction in people with Parkinson's disease. Even when she tried to set up this study, you can see that out of 167 patients with PD that were asked to participate in this study, only 88 agreed to participate and 62 refused. And we can just imagine why. I have loads of reasons in my head. The key finding in this study were that sexual function was a concern for 25% of people with Parkinson's disease, with men and younger people expressing the greater concern for that. Males and those with higher UPDRS, we referring to where mobility is more affected, are more likely to report problem in their relationship. And spouses and partner are more likely to express concern over marital problem if the spouses have greater cognitive deficit. Also, 75% of people with Parkinson's disease experiencing marital problem also express concern about sexual function, and emphasizing that the relationship between impaired sexual function and well-being. And concern will also express regardless whether you live at home, in a resident home, or in a nursing home. The problem may exist in any patient with PD, not just those who have long-term relationship or living at home. And the presentation of sexual dysfunction is diverse. It affects male and female slightly different. Although we have some common issues between both sexes when talking about sexual dysfunction, they're slightly different in terms that with male, we're talking about difficulties reaching orgasm, erectile dysfunction, ejaculation problem, hypersexuality or compulsive sexual behavior, side effect of medication that we treat with Parkinson's disease, and also impaired sex drive and reduced libido. When we look at female, we have difficulties again with reaching orgasm, vaginal tightness, loss of lubrication, hypersexuality, compulsive behavior, medication side effect, and again, impaired sex drive and reduced libido. Now, one will argue this is the kind of thing, an issue that may people healthy control without Parkinson's will come across as they age. And yes, indeed, that is right. But when we're looking at people with Parkinson's disease, the percentage is high. And let's look at other things that can influence sexual dysfunction. Depression and anxiety contribute to sexual dysfunction and impair sexual fulfillment. Moderate depressed people with Parkinson's disease would lose interest in pursuing sexual activities and will be very difficult to arouse. Medication use for depression and anxiety will also have an effect on intimacy and sexual function. Looking at sexual function in PD, it's commonly associated with motor disturbances, emotional and cognitive difficulties, sleep disorder, and side effect of medication. Each of the motor and the non-motor symptoms of Parkinson's can create this further emotional and physical, as well as cognitive difficulties, which may express in change in the intimate interaction between people with Parkinson's disease and their partner. So sexual dysfunction in a patient with any chronic neurological condition is bound to be multifactorial. We're looking at intimacy, and sexuality and intimacy are a huge challenges that face people with Parkinson's disease, as well as their partners. Intimacy is a very important aspect of human behavior, and it involves communication, physical and emotional closeness, and interpersonal interaction. It's not all about sexual intercourse. Open channels of communication are essential for decent quality of life. When we're looking at sexuality, it's one of the primary manifestations of intimacy. And intimacy could be holding hands, a cuddle, as I said, not just sexual intercourse. Sexuality is a basic human right, an essential part of healthy life. It is a complex process that it's influenced by the interaction of biological, psychological, economic, political, and cultural factors. Sexual dysfunction is a problem that affects one's health and as well as their emotional and physical well-being. And that's why it's such an important topic to address in our clinic. Indu mentioned about the neglect of the non-motor symptoms in Parkinson's disease. And although there's so many studies to highlight the importance of addressing the non-motor symptoms in Parkinson's disease, yet often it's a neglected aspect of the care in clinical setting. Here I have a slide, and I'm going to add all the bits to it. For me, when I'm looking at people with Parkinson's disease, there's a reality, different reality when we're looking at intimacy and sexual kind of function. And indeed, on the motor symptoms and on the non-motor symptoms, in those two boxes that you can see, there's many aspects that can affect a sexual relationship. And I'm not saying that one have all of these issues when we're talking about motor and non-motor symptoms, but take just one aspect of motor symptom and one area of non-motor symptoms. And when I'm giving this talk to healthcare professionals, I always said, I'm going to read to you many of the non-motor symptoms of Parkinson's disease, like constipation, bladder dysfunction, daytime somnolence, difficulty with concentration, saliva drooling, fatigue, impulse control disorder, memory problem, mood disorder like depression, anxiety, pain, sleep disturbances, sweating. And then I say to them, how sexy do you feel if you even have just one of these non-motor symptoms? And then look at the motor symptoms. If you feel stiff and rigid, if you have tremor, if you have difficulty turning in bed, if you are slow in your movement, or if you have that mask face on your face and you look like if you're not interested, but actually this is just the mask on your face. You have a completely different person behind that. And the dyskinesia, all of which can affect relationship and sexual life, all of which we can affect and lead to low self-esteem, feeling of being less attractive, and feeling less sexual. And unfortunately, all of which can lead to significant reduction in quality of life, as well as sometimes accepting that maybe this is it. I'm not going to have any more sexual kind of relationship, and maybe this is a thing of the past, and not pursuing it and trying to improve this kind of aspect of life that is so private and so personal and so sensitive to communicate to healthcare professionals. So impaired sexual function lead to reduced frequency of sexual intercourse, or even accepting that this is just not existing amongst male and female. And often people with Parkinson's disease refrain from making intimate advances themselves. It's because they are worried about the fear of being rejected or fear of failure. And this is not only affecting you, people with Parkinson's disease, it's also affecting your partners. And partners of people with Parkinson's disease experience sexual dysfunction as much as you, people with Parkinson's disease. Spouses often feel rejected and sometimes feel insulted when the partner appears to be ignoring them intimately or sexually. Because of their fear, they may not even initiate that. People with Parkinson's disease may refrain from making this intimate advance themselves due to this fear of rejection and failure. It's kind of a vicious circle. And the role of the partner and the caregiver. You are not used to be caregiver. You used to be a partner. You had a different role in the past. And the partner depends on the severity, the amount of care they're giving to their spouse with Parkinson's disease. You know, have to take a different role, which they are not used to. Partner or spouse have their own natural feeling and their need for intimacy and sexual activities. And as a caregiver, they learn to cope with the implication of chronic progressive illness. Caregiving and being caring is demanding. It's a lot of time. It's requiring a lot of attention. And often the caregiver, the partner, becoming quite tired and fatigued themselves. People with Parkinson's disease and the caring partner spend too much time together. We all know in any healthy relationship, we need to have some time apart. During this pandemic, we're spending a lot of time together, which can be challenging for people with Parkinson's disease as well as the care for any relationship, being with Parkinson's disease or without. It is overwhelming. It's feeling some time of frustration, depression, fatigue, and sense of loss for the carer as well. That loss of that partner with that sexual kind of role that they had before, if it's stopped. And there's a buildup of unresolved stress factor contributing to undesirable characteristics within the relationship. When we see people with Parkinson's in our clinic, we always ask them to complete this non-motor symptom questionnaire that was devised at this center at King's College Hospital, led by Professor Chowdhury. It covers all aspects of non-motor symptoms that we talked about before in that table that I showed you on the right. In this questionnaire, there's two questions trying to address sexual dysfunction. Here we have the opportunity to allow people with Parkinson's disease to disclose to us about two areas, and two questions here are about feeling less interest or more interest in sexual activities, and finding it any difficulties with having sexual activities. So it's a start. I know by no means that's where it's ending, but this is a way of starting the conversation and bringing that very sensitive, very private, very personal topic to the table to discuss with your clinician. But let me tell you what I often see with this questionnaire, with these two questions. those two questions quite often left ignored. Neither yes, neither no. Most of the time, there will be a no, not many taking yes. And so there is an opportunity here that it's missed. But the way we look at that is that don't take it, I always say to clinicians, just because they ticked it yes, does not mean there's no issues. And sometimes when you say, why did you tick no? And they will say to me, well, because it's not existent. So we don't want to pursue that. And that is okay. We are not going to wake up things that, people with personality, they just don't want to talk about. But certainly it's an area that we can start to talk about if it's a matter that's important to the person we are seeing. Another study that was very interesting was amongst the Dutch group discussing sexuality with people with Parkinson's disease. So they sent this survey to 139 neurologists, and it's a 22 question looking at barrier and frequency. Sorry, I'm just getting rid of this message, of discussing sexuality and responsibility for discussing sexual dysfunction. So let's see what the key finding here. So not all completed the survey, but it's good, kind of majority did. 21% of neurologists reported that sexual dysfunction is addressed by the nurse or counselor. I wonder if they know that, if they communicate that with that. Sexuality is discussed less often with female patients and those who are over 70 years old age. Why do we assume that when you reach 70 years of age, we don't have any sexual need? That is wrong, and we shouldn't make that assumption. 47% reported that patients almost never express sexual problems spontaneously. So there you go, we do need to ask this question. 22% reported to have insufficient knowledge re sexual dysfunction in PD. So we need to fill that gap of information and educate. And 56% expressed the need to have a further training in this topic. So more training is required. And that's why raising this topic in many meetings is very important with healthcare professionals. So let's look at the barrier in recognizing sexual dysfunction. Some people with Parkinson's are unaware that the sexual dysfunction is related to their condition or treatment, or as a result that they do not raise these issues with the neurologist. Like many of the non-motor symptoms in Parkinson's disease, they don't relate it to the condition of Parkinson's disease. And as I said before, it's not just about the sexual intercourse, the two questions that we see on the non-motor symptoms. In order to address sexual dysfunction, we need to address all of the non-motor symptoms, whether it's saliva drooling, whether it's fatigue, whether it's pain, whether it's problem with sleeping, etc. It's because of the sensitivity of this subject. People, not everybody can talk about it. And the lack of established rapport with clinician or insufficient consultation time. And you probably can imagine, you're going to see your consultant, your nurse specialist. We've got half an hour consultation. You've got a very pressing issue to talk about, whether it's your mobility or whether it's this and that. And this topic quite pushed aside and not discussed, but it is as important. And indeed, if there's not enough time during that consultation, I'm sure most of your clinicians will be happy to discuss it with you or the nurse specialist if you send an email and said, well, by the way, this is something that I want to talk about in my next consultation. Assumption about sexual activity at older age, as I said before, culture, attitude, religious belief, but not just amongst you people with Parkinson's disease, also amongst us clinicians. I know many colleagues that I work with who admit to me they will not touch that topic, they will not raise it, they do not feel comfortable. So I can just imagine what it's like to come to a clinician like that that doesn't feel comfortable talking about this topic. So as well, clinician knowledge on sexual dysfunction. And the way I look at it, I feel that the management of sexual dysfunction in people with Parkinson's disease is amongst all of the disciplines that are looking after you. So for example, if you're looking at the physiotherapist, I always say to physiotherapists, when you look at mobility in that, try to think for yourself as well. What is it like for that person to have any sexual activities? And try to think about when we're thinking about optimizing treatment. Often during the day, we optimize the treatment very well. But what about nighttime? Nighttime is a time that, you know, most people will relate of having sexual activities. We need to improve that ability to have that motor function, to have the ability to have that activities. Looking at the psychiatrists addressing depression and anxiety. I'm looking at the urologists that are helping us. Looking at bladder management, that is as important. Somebody is suffering from severe constipation. If we are unable to manage this in our clinical setting, involve the gastro department, the expert in that, to help the patient. Also, look at the dietitian, look at the speech and language therapist. Try and address the saliva drooling, the communication. This is part of intimacy. And I always said how sexual one can feel with saliva drooling if the speech is not is impaired and the partner cannot hear them properly, if they cannot communicate their need effectively. So the responsibility to address sexual dysfunction is amongst all of us healthcare professionals that are involved in the care we provide to you. So in conclusion, I would like to say that the data on sexual function in people with Parkinson's disease is incomplete. However, it is very well established that sexual dysfunction is frequent amongst people with Parkinson's disease. It is complex, but it is very clear there's a need to discuss it. And there's a number of factors that account for sexual dysfunction in patient population. And the management of sexual problem in PD is a challenging issue for physicians and all healthcare professionals. However, we need to remember that sexual healthcare is an important part of holistic approach to patient care, and it can have a direct effect on the quality of life. And we encourage physicians to discuss frankly sexual health issues with our patients and offer them treatment that based on a cumulative knowledge that we have on this topic with the treatment option that we have. I would like to acknowledge all my team that helped me with this work as well. Thank you. So,
That was
I need
great.
to wake you up now.
Yeah, that was amazing. I mean, I think you really highlighted the key issues, which are number one, doctors and the team, healthcare provider teams are not asking these questions. Even when they do ask the questions, patients are not really being forthcoming, and patients themselves are quite uncomfortable, even in questionnaires and in studies, to participate in this. So it seems like there needs to be a dialogue that happens a little bit more and ways to dig deeper. I think questionnaires, though, are a nice way to start the conversation. And I know, Miriam, that you were working on a specific questionnaire around sexual dysfunction at King's as well. Where is that questionnaire? I know you were showing it to me at some meeting maybe last year. How is that coming along? Could you maybe highlight a few of the things that you're digging deeper into and how you hope to roll that out?
Yes, indeed. So following this kind of interest that we develop here at King's in sexual dysfunction in PD, we were hoping to kind of develop a simple A4 kind of page, like you've seen the non-motor symptoms, yes and no kind of answer for people with Parkinson's disease to complete. And it's looking at giving them the opportunity to disclose to us, not necessarily in the clinic setting. They can take it home and complete it in their own private kind of time and send it back to us. And it's looking at all the areas that I talked to, whether mobility affecting their sexual function, whether communication affecting sexual function, whether mood and anxiety, saliva drooling, is their sexuality in terms of feeling sexy in a way is affected by the Parkinson's, and what symptoms are affected. And what we're hoping to do is that to develop and validate this questionnaire, and in order to be able to give it to people in clinical practice and allow them to disclose it to us. Because at the moment, there are some scales to assess sexual dysfunction, but it's amongst healthy control without Parkinson's disease. And I have to say that I tried to complete that. It's developed in Cambridge, and goodness me, there are very, very private questions there that I felt quite embarrassed and wasn't quite sure how I'm going to complete those kind of questions. So we were kind of thinking of a questionnaire that won't be too invasive, that would try to address all the non-motor symptoms that affecting sexual dysfunction. And we're hoping to start piloting it in our clinical setting in order to validate it in the next 6 months. In fact, during this pandemic period, we were hoping to start it. However, with the pandemic, everything stopped. So we do hope that we resume that in the future, the very near future.
Okay, that sounds really good. I hope that it does get to people. And I think there's been an interest in looking at the non-motor questionnaire. If maybe we could post that at the end, if you'd be willing to share that with us. Because I think that we don't use it in a standard way here. And I think it's a very helpful questionnaire. So definitely, I think we can share that. There's a couple of comments. Physicians, especially those who embrace a holistic approach, should never be uncomfortable discussing this topic with their patients. We are frustrated when we encounter that attitude from some of our neuros we've asked for guidance from. They squirm around like middle schoolers and change the subject abruptly. I think that's a pretty common experience. And I think, you know, I was pretty honest with how I feel. I think it's important to be honest about how you feel. And I mean, this isn't something, just to be really honest, I think in our fellowship training, in our residency training, in medical school, unless you go into urology or a certain aspect of psychiatry or OBGYN, and that too in subspecialties training, I think it's not part and parcel of our training, and really probably should be in a different sort of holistic model. So I think that's important to just be honest about things. I think, you know, when people can't be honest even about the barriers, then, and they pretend like everything's okay, that's really where I think, you know, the issues are. And I think, you know, as part of advocacy, if people find this as an important topic, and you're one of the few groups, I think, in the world, which is why I actually came to all the way to the UK to find somebody to find, you know, to be able to broach this topic. I think it's really not something that is, you know, talked about or written even about. There's not a lot of publications about it. It's really kind of in its infancy, I think, of being studied and identified and really treated too. So other things that have come up. One is is ED, so is erectile dysfunction as a younger adult an early symptom of Parkinson's disease?
Well, the sexual dysfunction, if you look at many of the studies, including erectile dysfunction, can be symptoms even prior to the diagnosis of Parkinson's disease. And we know that that is existing. Now, whether it is with all young people with Parkinson's disease, I cannot say that, but it's certainly established that these symptoms can be prior to diagnosis of this condition.
Okay. There's a question about, yeah, there's somebody else asked that, does ED happen before you notice any motor problems? And I would second that. I think the autonomic nervous system can get affected in Parkinson's disease. and in some other Parkinson's related disorders. And we do ask about those questions on presentation as something that helps us, you know, with an understanding of the autonomic nervous system, because this is intimately, you know, part of that nervous system, and erectile dysfunction would be in that category. There's a question about, will Viagra or Cialis work for ED in people with Parkinson's? These are medications that are in the, you know, that are used I'm assuming you know those names, because I don't know if it's different in the UK.
Yeah. So yes, and quite often people with Parkinson's disease that ask me this question, they're quite worried about will this medication will be okay to take with the Parkinson's medication that they're taking. Yes, of course, you will have to speak to your I don't know if it's a family doctor, we call it general practitioner here, to look in a bigger picture if there's any other contraindicating for you to use that in terms of cardiac problem, etc. But in terms of if you just have Parkinson's disease without any cardiac problem, it should not interfere with the medication that you're taking.
Okay, that sounds good. There's a couple of questions here about impulse control disorders and impulses. So I will read them. One is, I'm trying to get my husband with Parkinson's to understand that he needs to control his impulses. He cannot take no for an answer and usually approaches me for sex when I'm totally not in the mood. His voice is impaired and our communication is difficult. So I feel that he doesn't care about my feelings. His, I think it's speech, maybe, I don't know, it says SD. I'm not sure if that's speech, but sexual dysfunction or speech dysfunction is very bad. And he's a private person. So both of us are affected. I am no longer interested in sex, but I cannot get him to understand. I try to give in to his needs, but it's not romantic or loving.
Yeah, this is something that occasionally we see in our clinic with impulse control disorder and hypersexuality. I think one of the things that it's important to look at, you know, is the management of the Parkinson's disease. So, for example, if somebody presents to me with such an issue, and partners do talk to me about it, and then if I see that the person involved is, for example, on dopamine agonist medication, we know that with some of the dopamine agonists, different dopamine agonists will have a different percent, but there is a high risk of developing this kind of hypersexuality and compulsive behavior. And this is one of the compulsive behavior that it can manifestate. And so I think to begin with, I will try and look at the medication, and if certainly they are taking dopamine agonists, I'll try and adjust that. Another thing that's really important to say, you know, it's a relationship, it's a partnership, and it's really important to communicate each other what they feel comfortable with in terms of the sexual activities that's going on. And so I say, to add to that as well, is that sometimes we hear with people with Parkinson's disease that experiencing that is that because the sexual dysfunction, because quite often when they're trying to fulfill this act, not always they're succeeding. As such, it's something that they're trying to pursue again and again and again, because they never actually achieve that. They never reach the orgasm. They never achieve this fulfillment. As such, it feels like if they never achieve that, and they will try again. It may appear that they're with hypersexuality, but if you never got that fulfillment to begin with, and you keep trying, that is difficult for the person with the Parkinson's disease and to the carer. I would say that it's really important to look at maybe alternative ways of fulfillment of this kind of the need of sexual fulfillment, and also maybe trying and get to some kind of therapy to get an understanding between you and your partner in terms of what is comfortable for you, what is feel right for you, because it's essentially it's affecting both of you and both qualities of life.
Absolutely. Yeah, so I second that. I think there's a group of medications called the dopamine agonists that are more likely to, it's not just those medicines, but if you're on them, so that includes things like pramipexole or Mirapex, ropinirole or Requip, rotigotine, which is a patch. Those are the main ones that we're still using in this country. And those actually put people at a much higher risk of impulse control disorders. We're going to have Dr. Weintraub come on, who's a psychiatrist, who will be speaking about those a little bit more in detail. But those can definitely lead to hypersexuality, sometimes changes in sexual interests. So people have, fetishes that develop or other interests outside of who their partner should be, sometimes pursuing more pornography, which I think was a question here. Of somebody watching more porn. And these things can actually be part of the impulse control issues, and people can get out of control with pleasure-seeking behaviors, not just in these. And so we'll be talking a little bit more about them. Sometimes when we adjust the medicine, it can actually help a lot. So that's definitely important to bring this to the attention of your doctor if it is affecting you in your home as a spouse or as a patient. Definitely something that we can do as clinicians to help you with that. There's a question here about, I'm not married and my clinicians assume I am not sexually active. It makes it embarrassing to bring this up with my doctor. Any advice?
Yes, it's something that we touched in one of the studies that was done by my colleague, Annette Hand. There's this assumption that just because we are not in a relationship, married or in a partnership, that it's not a topic. Well, you need to bring the topic to that physician that is seeing you. This is something that it's important for you. As such, you need to communicate that to the doctor. Maybe we need to correct that assumption. And if you bring it to the table to the clinician, you may be surprised and they will be able to talk about it with you. But if you don't bring it to the table, if you don't say it, they will not know.
Absolutely. There's a question about, I think, let me just find it. Sorry. I think that I would second that. There's about someone who's older, in their 70s, and is single and is masturbating a few times a month and asking if that's normal.
Yes. Well, absolutely. We shouldn't assume that above 70 do not have sex. That's an old myth. Let me tell you, I discover a lot of things in my clinic, and I'm sure it's amongst a healthy population, not just for people with Parkinson's disease. Yes, that is actually normal, and masturbation is another way of getting sexual fulfillment. And that's another way for people with Parkinson's disease, that when we talked about if there's increased need and it's too demanding for their partner, maybe it's another way of trying to address fulfillment without imposing too much on your partner.
Absolutely. I mean, I think what we're really highlighting here is the discomfort that it's not because we're bad doctors or we're bad nurses or we're bad anything. I think everyone hopes to, we all go into medicine with, and that's why I spend some time finding out why people do what they do, because it helps me to learn more. I mean, I've known you, Miriam, for a long time now, and we've known each other through meetings and other things, but it's so helpful for me to understand what it is that makes you tick, so that we can, learn more about how to inspire people in this time frame. So, but I don't think that there's a lack of interest. It's just, there's a discomfort, and there's a lack of, I think it's really a lack of education of how to approach the subject. And I think one of the things that was shared here was the fact that they thought that an internet questionnaire or an email kind of interaction would be a lot less awkward than face-to-face, or a questionnaire maybe in the clinic. I don't know if that's been explored. And in some ways, if you were rolling out the COVID I mean, the sex questionnaire, the non, you know, the King's one, maybe COVID is not a bad time to think about rolling it out because, you know, maybe this is something that is a time frame that we could address these things and maybe have a little bit more time to reflect on what makes a difference for our patients' quality of life. And, you know, ultimately, I second what you said, that, you know, I think we're really talking about largely dyads right now, people in their home with their care partner, and how to help those two people that are basically in like stuck at home with COVID and are stressed out and really don't have the opportunity to reach other people. And I think the work that you're doing with the nurses, connecting with people in their homes, calling them proactively, figuring out a network. And what Miriam was describing was, you said a performa, which is basically a template of how to run a phone call. So you're basically teaching all the nurses in the country how to call in to a patient's home and find out how they're doing with Parkinson's, which is such a cool thing. I'd love to get that template as well. So I think at the end of this, we'd love to get there's been a request for your slides for your non-motor questionnaire. Possibly they could look at your sex one when it comes out if you're open for prime time for that. And maybe we could share it here and maybe people can report back to you about what they think. And then also the, you know, the template or whatever for the nurses' phone calls, because I think that could really help a lot of people be able to connect and approach this topic. So there's been just a couple of comments. I think people have really enjoyed this and have said things. I appreciate honesty from doctors' perspectives and your perspective. The more we talk about it makes us uncomfortable, the more productive the conversation. So I think just identifying the discomfort is helpful. Zoom in the meeting is very helpful to address this topic. So yeah, I mean, I think there's been a lot of benefits and people have really enjoyed the honesty and being able to talk about this and start, I think, the conversation. I think we haven't got into treatments, which is another whole topic and possibly not necessarily a topic for this time frame, but, you know, try and identify the issues. And I think, as you mentioned, the treatments are going to be possibly delivered from that sort of, you showed that picture, a therapist, I think a sex therapist could be very helpful. The neurologist has to be part and parcel of the conversation, and possibly, you know, a urologist, a gynecologist, some other folks that really are going to be involved in it. So, but I think the first thing is just to start the discussion.
Absolutely, absolutely.
And I really appreciate your comment about the communication too, because I think when we're talking about caregivers, I feel like sometimes there's a huge guilt about not providing all the needs as a caregiver to the patient, right? It's like you know, but like nobody signed up honestly when they got married or whenever. I tell this to my patients all the time. You didn't sign up to be nurse or you know, sometimes it feels like you're enslaved or you know, it's an interesting, you know, thing that happens. But there's this mindset that you have to provide for and sometimes hide your own needs or your own stressors. And as I've mentioned many times on this series, we have to care about our caregivers, because if something happens to you, then who's going to take care of our patients? I think that's so important, is in sickness and in health. Yeah, somebody wrote something about that. It's helpful to understand that just because we don't agree with something doesn't make it wrong. Yeah, so I think there's a lot of beautiful topics. Miriam, I'm going to give you the last couple minutes to maybe just say something inspirational, maybe point people in a couple of resource directions if you want to, and we can post them. Yeah, I'll just let you close. And thank you so much for, you know, doing what you do and spending the time on a Friday night there to join us. We really appreciate it.
Well, thank you, Indu, and thank you all for listening and for inviting me for this platform. It's a pleasure talking to a new, different culture and different country in terms of on this topic. So this is fantastic. I really just want to say that in terms of resources, I always refer people with Parkinson's disease to, in the UK, we have the Parkinson's UK, which is fantastic. And I've been super updating the website, in terms during this COVID-19 with all different aspects of ways that it can affect people with Parkinson's disease. Another platform is the Parkinson Foundation, fantastic resources, and the Michael J. Fox, all of which are, if I am to refer any person with Parkinson's that newly diagnosed, I refer to these three websites, because they're reliable and the information there is green, and what you get is all data that is scientifically written. So I really say that do visit those websites. In terms of just finishing that, I think that we are in a very strange time with this COVID-19 pandemic. It's impacted on all of our life. And particularly for the one that are at home and at high risk and unable to even go out for the shopping or anything like that. It's impacted people with Parkinson's in terms of people coming and visiting them, their ability to socialize, to exercise, to lead that life that they used to. It affects all our society, but I really feel for you people with Parkinson's disease, because being locked down for so long inevitably will have effect on your mentally and physically. And as such, I really, really want you to try and think of positive things that's coming out of this pandemic. And there are a few that we can think of. And it's brought a lot of family together. It's brought a relationship together. I'm sure there'll be plus and minuses, but there's a lot of good things that we can draw out of this pandemic. So I always like to finish with a positive note.
Absolutely. So, and honestly, from my perspective, it's brought us globally more connection. So, and we have speakers that are coming to us from the UK, from Australia, and I think it's really helpful to think about, and hopefully some Canadian, we've had a couple Canadians too, actually. So we, hopefully it will teach us a little bit about when we're reframing these conversations moving forward, how to take all the knowledge that you guys have gained from all this experience in other countries. So I really, really appreciate you fighting through the time zone issues and connecting with us. Thank you so much. I really appreciate it.
And thank you for inviting me.
And Andrea, back to you for our final wave to everyone.
Yes, thank you to both of you. Have a great weekend. Thank you for everyone who joined us and asked questions. Just the openness and the honesty and the vulnerability today was just really inspiring. And what a great way to say goodbye and do our usual wave. Miriam, we always just like a little bit of eye contact at the end of these and some silly smiling faces and whatnot. So thanks everyone for joining us. Bye now. Have a great weekend, everyone. Thank you, Dr. Subramanian. Thank you, Miriam. This was excellent.